So, good morning and welcome everyone. My name is Sandeep Dahiya. I am a professor of finance and entrepreneurship at the McDonough School of Business at Georgetown University. I'm also the director of the newly launched initiative on business of health. First, I am delighted to introduce Georgetown University's Global Health Institute. Launched in 2023, this institute embodies Georgetown's commitment to advancing global health, drawing on the full range of our university's strength from science and medicine, to business, law, ethics. The Global Health Institute stands as a shining example of the core distinctive strengths that Georgetown has. The first is our Jesuit tradition, which calls on us to care for our communities, to care for the whole person. The second is our location here in Washington, D.C., that gives us unique advantages in building relationships with global institutions and leaders, essential in tackling global health challenges. This vision also builds on the work of four key centers at Georgetown: the Department of Health, the Center for Global Health, Science, and Security, the O'Neill Institute for National and Global Health Law, which is right here, as well as the Center for Global Health Practice and Impact. A couple of words about the initiative that I'm leading. I want to highlight that the initiative on business of health, our mission is very much aligned with the purpose of this gathering. The initiative is built around three core pillars, which are education, community engagement, and research. We are dedicated to equipping our students to become leaders in healthcare, the next generation of leaders in healthcare. We are aiming to foster dialogues like this one in events like this. And finally, we want to support research that is at the intersection of business and healthcare. Today's event exemplifies the critical role of innovation in advancing health outcomes worldwide. To drive meaningful progress, innovation must not only be fostered, but you need to put in place incentives that allow this innovation to happen. Also, we need to make sure that these breakthroughs actually are accessible to communities that need them most. And today's event also underscores this great partnership that DHI and friends have had back in March. Oliver told me that there was a great event that was about empowering civil society in healthcare. In September, there was a Capital Forum on faith-based organization to promote healthcare. So I think this is a wonderful collaboration. In particular, I want to thank Mark as well to reaching out to me. And I think, please thank you. I think the wonderful work that Friends is doing is their dedication and tireless efforts have made a profound impact on mobilizing resources for this great cause. As I close, I'm inspired by the spirit of collaboration. I see people from such diverse backgrounds, and I think this diversity of insights, expertise, and commitment that each of you bring can deliver the change that we need for the great challenge that we face. By joining forces across sectors and disciplines, we are building a foundation for a meaningful, sustainable progress in global health. Thank you for being part of this critical dialogue today. And I'm looking forward to the ideas, insights, and partnerships that will surely emerge from this conversation. Thank you.
Well, as the expression goes, I think this is the beginning of a beautiful friendship. And Sandeep, thank you. I'm Mark Lagon. I'm Chief Policy Officer with Friends of the Global Fight Against AIDS, Tuberculosis, and Malaria. You'll be hearing from our President and CEO, Chris, later on. Special thanks to Deus Bazira and Oliver Johnson with the Global Health Institute at Georgetown University, our co-host and partner now in multiple events. I really want to thank all of you who are online. You've shown great interest in this topic. We'll endeavor in an all too short session to bring a lot of you into the discussion. And I appreciate the senior executives and government officials and others in the health community who joined us today. We have three goals for the day, or for the 2.5 hours. And we hope to interrogate three things that would be a focus of a report to spring from this convening to come out next spring. First is just to focus on exciting innovations which have an opportunity to accelerate progress towards the epidemic control of HIV/AIDS and malaria. And we're going to look at innovations that are in the area of treatment, diagnostics, and prevention. In each case, a couple of the diseases, HIV, TB, and malaria, in focus. Our goal is to look at what's facilitating innovation come to use in the field. A second goal for today is thinking about what incentivizes innovation, what gets it to deployment and scale in practice. We'd like to look at the role of the Global Fund in incentivizing, market shaping, procurement, and facilitating affordability and access. And ask the question, what is it doing well, and what could it do even more of if it were more fully resourced? And so we should be candid about that. And I thank our colleagues from the Global Fund who've joined us. And then finally, our third goal is really to look at how, from beginning to end, communities are essential, that designing in innovation, deploying, implementing, having the user, as one might say in the private sector, at the center is crucial, and we'll look to emphasize communities. And with that, I'm going to turn to my boss, Chris Collins, to introduce our keynote speaker.
Good morning and good afternoon, everyone. And Sandeep, thank you so much. Mark, thank you so much for spearheading this event. I'm also really excited about today's meeting, but also about the partnership that is evolving. So thank you so much. Thanks to everybody who's here today. I'm really pleased to introduce Amar Ali, and he served as Chief Executive Officer of Vestergaard since April of 2023. Amar's leadership experience spans global and regional markets with a particular focus on Africa. Before joining Vestergaard, he was president of DSM's Africa region from 2021 to 2023, where he led the expansion of the company's operations and strategic partnerships across sub-Saharan Africa. Vestergaard is renowned for manufacturing bed nets to prevent malaria and has made significant contributions to the fight against the disease. As a member of the Friends Private Sector Advisory Council, Amar and his team have been instrumental in shaping our work, contributing valuable insights to our advocacy efforts and reports, such as our 2023 report on digitizing healthcare demand and supply in Africa. We're thrilled to have Amar offer keynote remarks. Please join me in welcoming him.
Thank you, Chris. Thank you, Mark. Thank you, Sandeep. Very honored to have been asked to do these keynote remarks, and apologies that I couldn't be there in person. As you might have noticed, I'm a relative newbie into the world of global health and malaria since early last year. But it's a very exciting time to have joined. It's been a difficult few years for the malaria space in particular, with progress kind of flatlining a bit over the last few years. We're not alone in that, by the way. Coming from the food systems space where I was for the preceding 12 years, I can tell you, unfortunately, the malnutrition, food security indicators are kind of similar since about the middle of the last decade. But the good news is, in the malaria space, and I think in some of the other disease areas you'll be talking about, there's a lot of exciting developments, all sorts of new innovations and tools coming through the pipeline, many of which you'll be hearing about today in the malaria space, the high-profile things, the vaccines, the genetically modified mosquitoes, all sorts of things kind of coming down the pipeline in the next few years and starting to be deployed. I've been at the center of the deployment this year of probably the biggest innovation that has actually been deployed at scale, which is dual active ingredient nets. We went extremely quickly from We went extremely quickly from producing none of these, so this is a new product, 12 months ago, to having deployed 40 million of them, or shipped 40 million of them in the last 12 months alone. And we're spending now millions and hiring hundreds of people to scale up even further to meet the demand from the countries via the Global Fund, PMI, and others. So it's been a really a kind of a crazy year, I must say, to be running the company. But it's been great to be able to respond to the needs of the countries and of our customers to get these really important innovations out there. The dual nets look like they're going to be a game changer in terms of efficacy for killing mosquitoes. 40–50% more effective than the previous generations of nets. And also helping to combat insecticide resistance as well, which is a huge issue in vector control. Of course, it's not the end game. Resistance will reemerge, and we're going to need a pipeline of new innovations just within the nets world to rotate and make sure that resistance doesn't become a problem again, as well as, of course, new tools that will focus on other things, on daytime biting, outdoor biting, and other things. But it's been really gratifying to be part of a very large-scale deployment of a game-changing tool in my first full year as CEO, and to see that going all over the world and all over Africa in particular. All of this really has been achieved through partnership, which is one of the big themes of today's event. And specifically, I should call out the Global Fund, who've been instrumental in enabling such a huge, fast scale-up for the manufacturing and deployments of these nets. We have and this is a relatively new thing in this space, a multi-year volume guarantee, and a new operating model with the Global Fund. And that's enabled us to make these big investments that we've needed to make in expanding capacity, knowing that the demand would be there. And also helping us to plan, just in terms of procurement, raw materials, also product standardization has been a big deal. It's very hard to ramp up and get economies of scale when there's too many different SKUs. So all of this with a lot of work that we've spent with the Global Fund team in collaboration with them, also in collaboration with NMCPs, national health systems, and the communities, to get all of these different pieces in place and to enable this fast scale up. That's just one of the partners we've been dealing with a lot. And I mean, just to call out a couple of others for whom all of this, who are critical to making all of this happen, who we work with very closely. The WHO. Now, with all the challenges that we're facing, reducing time to market for innovations is increasingly critical, and we've seen the WHO really focus on this in the last year or two, and really push on how we can get the process for market access more efficient, and somehow make the right kinds of trade-offs between time, between cost, and scientific rigor, all of which are sometimes pulling in different directions, and how to find a way through that to get the right result for saving lives. So we partner very closely with them, with IVCC, and also all the GLP testing facilities in Africa to make this happen. Communities also are a big part of today's discussion, and they are obviously the heart of this ecosystem, and engaging them is crucial to make sure we extract the maximum value from all of these tools. For example, nets, how nets are getting used, how sustainable they are. We ourselves have been partnering with civil society, with Impact Santé Afrique in Nigeria and Rwanda. We're just finishing a very detailed, large-scale survey to truly understand more about usage, collection, disposal of nets. Which, by the way, is a challenge for the whole industry. We're sort of doing something on it, but should be actually a great example for future partnering across the whole industry in a pre-competitive way, as should all these sustainability issues, to make sure that we can move the needle on that stuff too. We're also really actively looking at how we can get ex ante, in advance, and during the product development process, more social science, end user behavior type data to feed into future net designs, and then that should make sure that in the future we get even more tailored designs that are suitable for communities to use. Final point I'd make is, yes, communities are important, engaging communities is important, but we believe we need to go a step further as well. True development and, the biggest kind of prerequisite for health outcomes is, as we probably know, economic development. And so we believe we should also do our bit to develop the economies of the beneficiary countries we're in. And in our case, that involves boosting regional production capacity. So we have signed an MOU with the Nigerian Ministry of Health. We want to establish a JV with a Nigerian manufacturing partner to establish a facility there to bring production closer to demand, closer to communities, improve sustainability, and boost the resilience of these value chains. So I'll conclude by saying ending malaria and other diseases is going to require a suite of tools. It's going to require us all working, organizations on this call and others, working in partnership, and also aligning with both country leadership and community leadership too. We here at Vestergaard are really committed to innovating in partnership with communities, with civil society, and with the people and organizations we're already deeply in partnership with, to continue to make sure that the solutions that we develop in-house are sustainable over the long term and achieve the desired goal. With that, I'll conclude. Thank you.
Amar, thank you very much for setting the tone for us with a lot of the themes that we'd like to focus on. We're beginning with something of a malaria motif, but we'll be diving into HIV and TB suitably soon. So it's my pleasure to introduce Dr. Michael Adekunle Charles, who is CEO of the Rollback Malaria RBM Partnership to End Malaria. He's formerly head of the delegation for Southern Africa at the International Federation of the Red Cross and Red Crescent Societies, medical doctor, a seasoned diplomat, an international development professional. He brings deep experience in humanitarian and the public and private elements of the health sector to this. Welcome, Dr. Charles. Thanks for your thoughts.
Great. Thank you so much. And good morning, good afternoon, and good evening from wherever you are. First and foremost is just to say thank you very much for inviting me to this webinar, and to really thank the Friends of the Global Fight Against AIDS, Tuberculosis, and Malaria, alongside with the Global Health Institute at Georgetown University. The RBM partnership is a partnership of over 500 partners really working in the ecosystem in terms of trying to bring down the burden of malaria globally. Allow me to start with, some good news and then go into what I think, we could potentially do differently when we talk about innovation. Obviously, over the last 2 decades, as Amar has said, there has really been global solidarity and dedicated global fund support and support from many people in the room and online in terms of really ensuring that we come together and really try to bring down the burden of malaria. And we've seen 50% reduction since that time. And the good news is, obviously, this year alone in 2024, we saw 2 countries on the African continent that have been certified malaria-free. That's Cape Verde and Egypt. But as also has been rightly articulated, progress is stalling for many reasons, including, severe funding gaps, resistance to drugs and insecticides, as well as the increasing humanitarian crisis. And when we talk about innovation, we really need to look at innovation also from a community perspective. And coming from a community-based organization in my previous life, I really see, the value of communities when it comes to innovation. And I believe innovation can truly transform communities. That starts within the communities. Transformation and innovation really starts within the communities. And these community members are really the local voices that continue to shape the solutions. Communities provide obviously the valuable local knowledge, cultural context, and insights into whatever we do. I mean, we had the vaccines recently in terms of innovation. We have the dual AI nets, as has already been articulated. And we see that if communities are not really at the forefront of that, then the rollout will be difficult. The usage will be difficult. The cultural acceptance will be difficult. So really ensuring that in anything we do, we really start with the communities and ensure that we can also give, the needed, supports to communities to come up also with their knowledge and innovations. So I really believe innovation shouldn't just be about products, but we also need to innovate in terms of our partnerships. How do we do our partnerships? How do we make sure that there's that localization and really building strong community-based organizations, inputs, and systems to ensure that collectively we're really working together in terms of improving health outcomes as we go along. From the RBM partnership, we are certainly committed to ensuring that communities are at the heart of our interventions and they inform, provide, and implement crucial knowledge for any interventions and innovation. Just yesterday, we actually signed a partnership with the Geneva Learning Foundation, which has a real flagship initiative called Teach to Reach. Through this initiative, we have been able to open doors for organizations within our partnership to engage with community-based health workers, offering a platform to share real-world insights and best practices for combating malaria. As part of this peer learning network of over 60,000 health professionals across more than 80 countries, we have been able to ensure that RBM is really at the forefront in terms of ensuring that malaria control efforts are shaped by those who understand the challenges at first hand. Just like Amar as well, I really want to, lend my voice in also applauding the efforts of the Global Fund for its continued efforts to prioritize communities' access to health products and care by investing in resilient and sustainable systems for health that capture key principles of primary health care. This approach has really strengthened government and community health systems, including formal health systems. The question is that can we do more? Certainly, and as has been rightly articulated as well, I think for me, really leveraging on the partnerships with the private sector, with the civil society, with local communities, the Global Fund will continue to improve health outcomes, increase equity, and enhance health security. I think for me, it's really, again, to focus on the aspect of malaria and the need to continue to innovate in the right space. And we know that 2025 is a very important year in terms of the replenishment of the Global Fund. So really seeking everyone within the ecosystem, to see how we can ensure that, we have a successful replenishment. If we're not able to have a successful replenishment, obviously the gains that we've made in the 3 diseases might actually be stalled or might regress. So really this is, to support the continued efforts in terms of funding and to really support and empower communities, amplifying innovation and to reduce the burden of these 3 diseases, I think for me is really at the forefront. So I'll continue to engage in the discussions, continue to bring the community perspective, but I think at the end of the day, we really need to make sure that in everything we do, it has to be community-led and community-owned, and that's where our BM partnership, together with its 500 partners, are really driving towards in terms of reducing the burden of malaria globally. So thank you very much for giving me this opportunity. Really looking forward to the partnership with yourselves and really looking forward to the conversations around innovation from a community lens. Thank you.
Dr. Charles, thank you very much. And also really suited to kicking off our conversation. I'm going to start with a segment that is on innovations in the area of treatments. In particular, looking at some things related to malaria again and TB. I'd like to turn to Nkoya Otsiula. Dr. Otsiula is Director of Global Health Medical Affairs for malaria for Novartis. She's based in Nairobi, Kenya, but is at this moment at the ASTMH meeting in New Orleans, like a number of people are. Thank you for joining us. Dr. Otsula, do you have any things you'd like to share about malaria innovations, perhaps things that are tackling the drug resistance problem?
Thank you very much for the kind introduction. Please confirm that you can hear me clearly.
Can.
Perfect. So Novartis has been innovating for malaria patients for over 25 years now. 25 years ago, we brought artemether-lumefantrine, which is branded Coartem, to patients. And at that time, existing treatments were failing. This was the first fixed-dose combination artemisinin combination therapy, or ACT. And it goes without saying that over the last 2 decades, ACTs, RDTs, and that's rapid diagnostic tests and long-lasting insecticide nets have had a huge impact on the burden of malaria. And there were very bold decisions made to invest in these ACTs because they were relatively more expensive than existing treatments. Today, again, we face the risk of partial artemisinin resistance, particularly in the Eastern African region. And of note, 2 of 4 countries where this has been validated by the WHO are high-burden countries. And there's a real risk that we could reverse the gains that have been made towards ending malaria. At Novartis, we're working on a number of novel candidates. And each of these novel candidates is from a new class of treatments. And 2 of these are at an advanced stage of clinical development. The candidate that would address uncomplicated malaria is in phase 3, and the severe malaria candidate is in phase 2. These innovative compounds could be real game changers in the fight against resistance. They have the potential to reduce resistance pressure on existing drugs and stop treatments failing, and potentially could save lives and conserve the utility of other treatments. And through their transmission blocking activity, these candidates have the potential to simplify treatment in elimination settings where one has to use an ACT and an additional drug, which is often not in supply. However, these treatments, as wonderful as they may seem, will come to the market at a higher cost than existing standard of care, which is highly genericized. And significant investment is needed to make the treatments affordable to the countries and individuals that need them the most. This is not about one new treatment, but about having an armamentarium of treatments and interventions, all of which we will need to defeat malaria. And collectively, we need to create the conditions where important, new, fit-for-purpose innovations can be introduced and implemented quickly and simply, with the overall goal of elimination of malaria rather than addressing short-term financial goals. I hope this puts us at a good place to talk a little bit more about financing of new interventions. Thank you very much.
Thank you. And do any of our colleagues, particularly those who are focused on malaria, have something you'd like to chime in about? Do either put up your name card or your hand here in person or online. I'm interested, Dr. Otsula, how concerned are you about the drug resistance problem, and how confident are you that new innovations and new treatments or parts of combination therapy can come to use to grapple with that problem?
So the issue of partial artemisinin resistance is a major issue. So the 4 countries in Africa where it's been validated are Rwanda, Eritrea. Those are both relatively lower burden countries in Africa. They were actually on the path to elimination. And then there's Uganda and Tanzania. Uganda is, I think, about number 4, number 5 in terms of cases and deaths. And if this goes unchecked, then we really are going to reverse gains. We're starting to see signs of this mutated parasites being seen in Western Kenya. And there have been sporadic reports in DRC, so it's not something we can ignore. There have also been reports of tourists. You know, we might think that sitting in a privileged northern position, we are safe, but there are tourists that visit those countries and come back with malaria where resistant parasites have been picked up. So it really is a global health issue. The new treatments that I've been talking about, and for which we're going to be presenting some data at this ASTMH conference, have shown themselves to be efficacious against both artemisinin resistant and artemisinin sensitive strains. So while they themselves, by themselves, are not the full solution, you know, we need the full, you know, ACTs have their place, the new treatments have their place, we need bed nets, of course, we need the vaccines, we need everything on, you know, on board. But these new treatments could be particularly useful where we're starting to see this failure of treatments. Because what's going to happen is when treatments for acute and complicated malaria are failing, then you see more cases of severe malaria. And then that's a whole different piece of health system utilization. I hope I've answered your question.
That's very, very helpful to set up our conversation. And I'd like to look at, turn to another participant here, Darshan Trivedi, who's co-president and director of business and research strategy at Genomics in the Bay Area of the United States. You have some very interesting innovations related to treating malaria. Would you like to share that in any ways you're sort of anticipating what the needs of communities are as you develop it?
Sure. Thank you, Mark. Thank you for that question. So hello, everyone. My name is Darshan, and I'm one of the founders of a Bay Area startup called Genomics. We also have a site in Bangalore in India. We were founded in 2020 out of Stanford, where I was a researcher. And the founders at the company, in the past, they have created other billion-dollar biotech companies based on a technology that we are trying to leverage now in the global health space. So this technology is specifically developing novel therapeutics for parasitic diseases and especially malaria. So what this innovative technology does is basically at a very high level, it targets any sort of movement in biology. It targets the proteins which are responsible for movement in biology. And as you would know, malaria parasites and other parasites, they love to move, they love to invade cells. So when you inhibit or target these particular proteins, it stops the parasite from moving and invading cells. And that's exactly what we see in our early proof of concept studies, where we are seeing a pretty solid inhibition of both the Plasmodium falciparum and the Plasmodium vivax parasites. In addition, I think there was a lot of discussion about resistance being an issue in the malaria space. What our molecules are showing, they are showing efficacy against the already resistant species of the parasite, number one. And number two, our molecules are also refractory to resistance development. So a lot of these sort of early stage innovations, there are a lot of these early stage technologies which are wanting to come to the forefront. And someone mentioned about financing and fundraising and funding of these early stage technologies to take them to the next stage. So that's what we are doing at Genomics.
Thank you, Darshan. I should note that, of course, we're focused a bit on the Global Fund today, but we sit, those of us in person, just blocks away from the Congress. And not only is the Global Fund replenishment in mind, but the 20th anniversary of the President's Malaria Initiative that comes up next year, both which work intimately together, need the fullest funding. I'd like to pivot to TB, and there is no one better to start in on TB than our colleague, Dr. Dityu is CEO of Stop TB Partnership. She is well known to you in the community, so I'm going to not take any more of her time. And I'd love to hear from you about TB treatment innovations. In many ways, the Global Fund is facilitating their development, or could facilitate all the better.
So thank you, and great to see everybody online, and 93 people. 6 people dropped since we changed the topic. So let's see how much there is that much enthusiasm when they heard about TB. I'm not even joking.
I'm enthusiastic.
Let's see another one. You see 92. Just watch the screen. I will let you know by the end of what I speak how many will still remain when we speak about TB. I am counting. And I want to say that it's, first of all, really thank you to you, Mark and Chris, for inviting me and a few other TB colleagues or colleagues working on the TB space, and for bringing such an amazing gathering there. We really appreciate this. And I hope, we will be able to bring a bit of a TB flavor here. I have a very good skill sets on saying the things as they are and making myself unpopular, but as such life is. And, let's go a little bit on the TB conversation and on the TB treatments. And I want to say that we have a bit of a roller coaster, similar somehow to the malaria colleagues, because one way or another, we are on the same boat. We don't have anything to celebrate, any 20 years, any president initiative, but we are still battling TB. I'm the executive director of Stop TB Partnership, and I am a medical doctor transformed into an advocate for people with TB. So why I said that this is like, when you are on a roller coaster, you sometimes start high, you go down, then you go up, then you go down. So let's try this together now. We will go first down, and it's cutting your breath, and it's good to cut the breath, because the least you breathe, the least you have the chance of getting TB, right? Because in TB, you can sleep under bed nets and wear condoms and protect yourself or anything. As long as you breathe, you are at risk of TB. All of you there, all of us, and so on. Unfortunately, as you saw, TB remains the biggest infectious disease killer, as you saw from the recent WHO Global TB report, and very, very depressing and very worrying, and is linked to the topic before. We see very limited progress on the diagnosis and on the treatments and enrollments for drug-resistant TB. Basically, I was much younger, and some of you here that we know each other for many, many years, we are more or less at the same level of multi-drug resistant TB numbers, around 500,000, 400 to 500,000 people. We don't even able to diagnose and treat half of them. We are at 175,000, and that's the figure that we have for almost 10 years. It's airborne, huh? But, and on top of this, on TB is not only the disease, you see, we have also the infection, because according to WHO, between 20 and 24% of the world is infected with TB. So we need to do something about that. I am infected with TB, and several of you in the room, if it is to believe this data, right? I see our Vice Chair Austin here, so I imagine he's infected with TB as well. So we need to do something, not just about the TB, the disease, but also the TB, the infection. And the treatments are really, something that we should look at. But to be able to treat, at least for the disease, it's very important. We have to diagnose, right? We need to know who are these people. Now, we went a bit down with this. Let's go a bit up. Why is so much hope? And why, is not just all is, a disaster in TB. We observe, I will go to the new hope that we have, but what I want to say is that there is a lot of ambition in the high burden countries in diagnosing and treating with normal TB a larger number of people, and we saw in 2023 and we see in 24 historical numbers of that. So there is the ambition there. Finally, TB is not accepting anymore the status quo. But on top of that, there are some amazing innovations we have there. When I was treating TB, the treatment was for normal TB was 6 to 8 months. Now we have treatment for 4 months. The drug-resistant TB treatment used to take up to 2 years, and we had injectables, and it was a disaster because the injectables used to give a lot of side effects, including deafness. Now we have a treatment that takes only 6 months for drug-resistant TB. We have a lot of digital tools that are really ready, helping people with their treatment follow-up and adherence. And there are, believe it or not, chatbots for helping people to cope with the treatment, and a lot of AI and intelligent solution that a lot of developers are trying to put in place to help with the treatment. On top of that, there are, believe it or not, which is for TB, we never had this kind of interest in research. We have 29 drugs or combinations of drugs in clinical trials for treatment of TB and 30 for the TB infection. Sounds awesome, right? Sounds awesome, all the other things that the colleagues from malaria said. But the downside of all of this, all our innovation, and I know Mark, you will touch on that, and all of you, is that none of this is going to be amazing unless people use it. You know, unless these are reaching the people. It's amazing. It's like me saying, I have so much chocolate here, I can even show it to you, but none of you will have access to it, right? So how do we ensure the access to it? Is working on two sides, but both sides, which one of them is really scaling up and introducing it and facilitating the introduction of all these new tools at country level. I mean, do you know how long it takes from the moment I heard the colleague from Novartis about a new molecule? In TB, I don't think we have molecules. The only one that I know works on a new molecule is Otsuka, but everything that you try to introduce, it takes years, okay, for various reasons. You know, the pre-qualification exercise that, you know, the WHO is doing is looking at maybe in 3 years we give you an answer. You know, this is translated into a lot of delays and a lot of life saved. So on one hand, we need to make sure that we have the supply, that we have it available, that we have it quality assured. And on the other side, that we work, that people have access to it, you know, that irrespective where they are and how they are, and be aware. In TB, because we never had money, we unfortunately introduced something in the early 2000s in which, in the late 90s, countries with high income level were having certain algorithms for treatment. And if you are low income, then you don't treat MDR, then you don't treat children, then you don't treat extrapulmonary. It was completely unethical. So we moved from that. But to be able to secure access to all these amazing tools, and some, to be honest, some of these tools even seeing the light of the day, we need the money. And unfortunately, and I heard about malaria as well saying about this, we know all we're entering into a 2025 replenishment for Global Fund. I don't think Global Fund is the only, so I think Global Fund is a huge part of the solution, at least in TB, but I don't think we should drop everything only on the Global Fund. I think domestic funding needs to come, and I think some smart things need to come, but we also need to come together far more. And the one thing that brings us together, and I will end, otherwise Mark will never invite me again, is civil society and communities. And the ones that are the frontliners. The frontliners should not be used just for TB or just for HIV, just for malaria. They are very little used for TB because we don't have the money. They are mainly used for HIV and so on, but it will be really, really important to really look at the ways in which we bring them together for all the work that needs to happen. We kind of tried to learn a bit more during COVID than it was during Ebola. From Ebola, I think we forgot everything. We will forget from COVID as well. We're already getting there. So the need for constructing on each other's strengths and being partners, it will be extremely important. So I will stop here and thank you very much. I could have spoken.
Marvelous. Any comments in the room or online with regard to TB treatments? Okay, I'm gonna go pursue, and don't harm me, please, Dr. Ditu. I'm gonna go to a malaria comment, and then perhaps we can return to TB. Crystal Burungi is in Uganda and is an entomologist who we were delighted to have in Washington in 2022, doing great advocacy. Crystal, do you have any thoughts on that you'd like to share as a specialist on malaria treatments and innovations, and perhaps making sure you connect to the community.
Yes, thank you, Mark. I think this is a really wonderful forum, so I'm glad to be here to comment on that. I think when you come to countries like Uganda, where the burden of malaria is so high, and we lose so many lives to it, community can make a huge difference in that, both when it comes to existing innovations and when it comes to new innovations. So I often speak about when I was growing up and what the situation was like. And always I like to mention that one of the key differences that was made was when the Global Fund was training what they call the village health teams, which are basically community members that are based in the villages that are trained to diagnose and treat malaria, so that people that don't need to travel long distances to try and get to health centers or where the facilities are not working. So that made a very big difference to access, but it's also very key when it comes to any innovative measures, and also community engagement and communication when you're trying to educate the communities. So having the community involved at that level makes it possible for the access to the drugs to happen, but also for trust and for people to be able to accept, for example, the new mosquito nets or all the other innovations that are in line, mobilization for vaccines and so on. So all of this is truly key, and it's one of the cornerstone of the system that the Global Fund has put in place. They are partly funded by them, and they are also people who are trained by the Global Fund, basically through them. I work with Target Malaria, which is basically an organization working on one of those innovative measures, working on developing genetically modified mosquitoes to combat malaria. And that's one of the things that has been a cornerstone of the work that we do in the community, because the engagement of these communities is what builds acceptance in the long run. And it's very important to involve them at that point. And that strategy that the Global Fund put in place, or this framework that the Global Fund has put in place, is going to be very key for each of these systems to go on like that. So it's really important when we're looking at malaria treatment and innovations to think about that kind of framework. And I really applaud the Global Fund for that. And I'm also, like many people have mentioned, very hopeful for the replenishment, because we know that this takes money and it needs to continue for the effective use of these tools in the communities, for the education, for the development, and so on. So I will not take up a lot of time, but I'm really glad that you called on me, Mark, and I got to say that.
Thank you, and I hope you'll take part in later parts of our discussion, despite the hour in Uganda. Hey, Colin, did you have anything you wanted to weigh in on, especially spurred by the irrepressible Luchika?
I never say no to a chance to say something on TV. Thanks, Luchika. Colin with results. One thing that came to mind when Luchika was talking, and I don't have the data in front of me, but thinking of the roller coaster metaphor, the second to most recent breakthrough we had in TB treatment, Adekunle for drug-resistant TB, it took something like 7 years for most Global Fund countries, Global Fund supported countries, to roll out Adekunle and have access to it, as compared to the most recent treatment innovation that Luchika was talking about, that in the most recent round of Global Fund grant proposals, essentially every country included it in their request, like less than a year after the regimen was available. And so that speaks to the really, I mean, there are a variety of factors at play there, but to me, the most important one is the level of country ambition and commitment to reaching people with the latest innovations in TB. But what the other side of that story that is that also in this same grant cycle, a huge number of Global Fund countries don't have the resources available to cover many of the basic commodities for TB, and will run out of resources even before the end of the period. And so you simultaneously see this new innovation, increase in ambition and willingness to use and support people to access those tools, but then the gap in funding to actually deliver on it. So for me, it reinforces just how important going into the next replenishment cycle, and as Luchika said, across many sources of funding, but particularly the Global Fund, that not only sort of sustained resourcing, but increased resourcing is essential if we're going to make use of these tools.
Thank you. I'm going to pivot now to diagnostics and looking at TB and HIV, but let me start with TB, if I might. Again, from people who are quite afar and doing things in the middle of elsewhere. Chief Medical Officer for AI, company founded and headquartered in India, working in some 90 countries, leveraging artificial intelligence in TB scanning. Dr. Vijayan, you have some thoughts you'd want to share about innovations in the area of TB diagnostics? Chibu, are you able to join?
He was online. I could see him. I am perfectly equipped to speak on his behalf if he doesn't, but let's see.
Claiming this time.
AI was one of our babies, so that's why. Many years before Shibu was the adult, he was my son. So I'm joking, but Shibu supported them in growing where they are right now. But Shibu, I hope you are around.
Enla Fees, you are also with Curia. Do you want to say a word until Chibu might be able to join us? I know he's imminently to get on a flight to leave Bali, where we are quite aware of the time. Enla, do you have a word to say?
Absolutely, I can do. And first of all, just to say thank you so much for having us. As Luchika kindly said, we have been working in this space for quite some time. And I think it would be fantastic if we could hear from Dr. Shibu, whose background is quite esteemed and prolific in the space of TB and community programs. He himself is a TB survivor, then ran TB programs globally at PATH for a number of years and has transitioned into Cure in the last couple of years. So if it's possible, I would love for us to move back to him after hearing from some of the other participants, but otherwise I'm very happy to jump in on his behalf if not.
Fair enough. Let's shift temporarily, but importantly, to HIV. Friends of the Global Fight is really graced to work in partnership with the Elton John AIDS Foundation, including on a report on how single disease efforts can be leveraged for broader health gains in a report jointly done with UNAIDS. But Lindsay Hayden is Senior Portfolio Lead for Youth for Adolescent Health and Prevention Technologies. And we've talked recently about meeting youth where they are, self-testing, exciting innovations. Lindsay, would you be willing to speak to that?
Yes, absolutely. Hi, Mark. Good morning, good afternoon. Can everyone hear me?
Yes.
Oh, brilliant. Okay, fantastic. Yeah, it's, first of all, really, really honored to be here. I think Mark and I have had numerous discussions just talking about how at the Elton John Foundation, we've been trying to really think through how is it that we can, more effectively engage youth, particularly in the prevention arena. And we all know all the epidemiological reasons as to why youth are such a critical group to grasp, and probably are aware of all the reasons they're difficult to actually be able to get to. And so over the last couple of years, we took a kind of, I hate to sort of use Silicon Valley speak, a sort of venture capital type approach in terms of how we went about thinking about youth. And the two themes that kind of overlaid on top of the different investments we made were really, how do we decentralize care? by the way, we recognize we're not recreating the wheel here, that many of you have come here way before us, but sort of decentralizing care, bringing it as close to youth as possible, and then, horizontalizing care, this idea of one-stop shopping. As many of you know who may have teenagers or were a teenager, this sort of, traditional idea of us expecting youth to kind of tie themselves into pretzels, to engage with care, to access care, to even recognize they need care, is sort of a misnomer, and then making it incredibly difficult for them to be able to actually reach resources. And then they get to, care units where, it can often be housed by healthcare workers that are sort of moralizing, or certainly they aren't fit for purpose. And a lot of times they can be retrofitted pediatric or adult services that are not really fit for need. So we sort of thought about, okay, who are the very cool innovators out there who could help us, really bring services to young people in an interesting, effective, and cost-effective way. And while I realize we don't have all day today, I'll just mention, one of the grantees we've been working with, because I think there's sort of a really good paradigmatic example of sort of what can be done, particularly when you sort of start to integrate some of the private sector thinking into this arena. So we've been working with Zipline for about 2.5 years now in Kenya, initially in Kisumu. We're now in sort of 8 other counties with them. And as many of you may or may not know, they're a autonomous drone company. And they basically are able to deliver end-to-end products from point A to point B effectively on demand. And what we started doing with them, in concert with them and our wonderful partners at Empath, was setting up sort of pop-up events at unconventional locations where we knew youth were already frequenting. So think nightclubs, think sports grounds, think community centers. And the idea was that, you would have, these pop-up events would sort of be circulated within communities. They worked very closely with local CBOs, key pop CBOs, et cetera. And that then there would be both doctors on the ground to, provide all sorts of services for young people, but that also, anyone that showed up on demand, they could request, certain types of SRH, sexual and reproductive health, and HIV commodities that would arrive within 15 minutes. And what we found was really interesting, which was, in other parts of our portfolio, we've actually been focused on direct to consumer, which you'd sort of think, okay, fantastic. This, if I can actually order a product and it goes directly to me at my home or at a post office box or wherever, fantastic. Well, actually, some of the greatest, impact we've seen is in these pop-up events, because what we didn't account for is the social element. And so what's been really extraordinary with these events is that not only have young people showed up, but actually all parts of the community have showed up. And because the attendance has been so outsized, the county governments have been overlaying on top of the HIV services all sorts of other services. So it has become naturally, we were hoping for this, but we couldn't have guaranteed it, a sort of one-stop shop where they now are doing NCD, they're doing all sorts of diabetes care, cardiovascular care. We're doing now, they overlaid vaccinations, and actually we're now doing some more work in Nigeria with Zipline and with Gavi, where we're integrating vaccines into these types of things. And it's just been really quite extraordinary to see, one, I guess, when you start thinking about bringing care as close to young people as possible in a kind of anonymized fashion, where it's a multitude of different, healthcare outlets that are there. So nobody knows why you're there or how, for what reason. There's a really significant, impact. And what's also been really, really interesting for us, and I'm sure many of you have to deal with as well, is, supply chain efficiency and issues like this. And what's been really incredible about Zipline is, 100% of our PrEP orders were fulfilled in full and on time, 100% of ARV orders fulfilled and on time. And in addition, the supply chain transparency that an entity like Zipline gives you, where you literally can see end to end where the commodities are going, has just eliminated, issues that, that could pop up with sort of waste or inefficiency, et cetera. And also, have allowed for counties to do much more effective forecasting. And as I think one of the speakers was speaking to just a second ago, we all know supply chain is a major issue. And so, finding ways of being as effective and cost effective as possible has just been mission critical. So I'm going to pause there and toss it back over to Mark.
Thank you, Lindsay. And I'm glad that you brought up supply chains, because we'll address later some things that are not commodity specific or not solely specific to HIV, TB, and malaria interventions. In fact, quite soon we'll touch on supply chains. But I want to ask, does anybody here in the room or online have a comment or a question regarding HIV diagnostics, or something that Lindsay has prompted you to raise? You can always reclaim your time later. I always look to you, Oliver, at times if you have things you want to raise. Well, in that case, Lindsay, if you don't mind sitting tight, I was limited. I'm going to pivot back to TB, and then we could collect any comments on either. Dybul Vijayan, thank you for joining us from afar as Chief Medical Officer for Global Health at Cure AI, QURE.ai. Some thoughts on your work in many countries on innovations related to scanning?
Yeah, so thanks for the opportunity to talk. I mean, it's pretty difficult to impress the audience after Luchika speaking, and she made a compelling case of tuberculosis. But I'm not want to. I mean, she was also optimistic in saying there are innovations in the space of tuberculosis, and I represent a company which actually provide innovations in the TB screening and diagnosis assistance. So we started in 2016, essentially focusing on interpreting chest X-rays with artificial intelligence and providing reporting capabilities and the probability score of tuberculosis within less than a minute, which enables people, I mean, the frontline health workers, the doctors, and increase their capacity to decide on the subsequent testing. And Luchika also touched upon the advancements in the molecular diagnosis, which are capable of taking the technology to, I mean, diagnosis the point of care, either by collecting the samples or leveraging the tiny part of the technology. Most of the advancements happen, the bigger machines have gotten shortened and tinier, which enables to take it to the communities level. So we are part and parcel of that kind of packages of screening and diagnosis. So thus far, we have touched upon 25 million lives. So one of the key challenges is that even if we are technological advances in the space of TB for screening, and AI is been advancing in the healthcare domain, one of the key challenges is that we have 30 high burden countries. It's only 30% of the high burden countries have reasonable scale of these technologies happening. So I would strongly advocate for rapid scale up of these technologies, because anything on digital AI is suboptimal if you're not scaled up. So patchy scale up is not going to help you out. The scale up, rapid scale up is something which we would want to advocate to, and also thanks to Global Fund for supporting this innovations. But again, that I would say we need more. 30% of only 30 high burden countries scaling up such innovations is suboptimal. So that is one part of it. Similarly, so this is on TB diagnosis. We have a huge gap in latent TB diagnosis. We have 1.7 billion people infected globally, and only 21% of the eligible people who were targeted to be put on latent TB infection is being diagnosed and put on treatment. That's a critical gap. So there are advances and innovations in that space. Again, there is a lot more advocacy, awareness, as well as point of care tools, affordable tools need to be there in the space. I just want to stop there and say, hey, the only single point I just want to drill down is that don't wait for innovations to come. There is enough innovations right now. Let's actually scale it up and reap the benefit of it now. Thank you.
I welcome any comments on either HIV or TB related diagnostics. I know we have some folks with companies that focus on diagnostics and various diseases, Roche, Abbott, and others. And what we may do after bringing in a third perspective, have some time for cross-cutting discussion about innovations on diagnostics.
Can I ask a follow-up question to the previous speaker?
Absolutely.
Forgive my voice. My name is Antonia Powell. I'm with JSI. My question, Dr. Shibu, was you spoke about the limitations on scale up, and I presume that utilization of an facilitated diagnostic would be quite cost effective, quite a bit more cost effective than the utilization of, maybe dispersed radiologists as a turnaround. Yeah. I'm wondering if you could speak a little bit more about why funders perhaps have been limited in their ability to fund the scale up, or a little bit more around the economic implications of the scale up. Thank you so much.
Thanks.
There is a patchy in the net. If I understood the question, is the limitation is the technical expertise, or is it the limitation of the technology penetration itself? Is that the question?
My question was more around the limited scale up. I presume that this technology is more cost effective than traditional diagnostic interpretation. And so I wonder if you could provide a little more insight around the limitations to scale up.
Correct. So there are two key critical limitations. One is the cost effective part of this, because the molecular tests currently available in the TB domain are pretty expensive. One of the key things, the X-ray and AI comes in optimizing that kind of resources, because we could actually kind of identify and rightly target the probables, presumptive cases in a better way, because we are using better specific and sensitive tool, kind of filtering out, improving the pre-test probability of the subsequent test, the confirmatory test. So a number of tests will be reduced, then that is cost effective. Second thing is that typically when AI is being used for active case finding in a remote setting with a tinier X-rays, ultra portable X-rays, which is also a cost intensive exercise, because the hardware cost and CapEx cost is heavy. So what we are now advocating is that there are already billions of X-rays happening for whatever reasons, like because test X-ray is the most used diagnostic imaging technology in the globally. Why can't we leverage already happening test X-rays with AI? And we do have experiences coming out from the company, from many countries, in leveraging existing happening X-rays for whatever reasons. So maybe for pre-anesthetic checkup, wellness checkup, and we are finding 30% of such cases are asymptomatic. They are coming. AI is flagging cases which are incidentally found, patients who are showing up in the health system. So what we are advocating is that the cost for active case finding is so relatively intensive when you compare to hardware and software and mobilization costs. But you have a low-hanging thing. You have facilities which is already enabled with X-rays. You power that with AI and then try to leverage incidental case finding. So that's something which we are anticipating. Every country should be able to optimize their case finding minimum 30% uptick on overall microbiological diagnosis. The quality of diagnosis will improve. More number of patients will be incidentally detected. Hence, early detection will be there. There'll be a huge dent in the infection transmission also. So that is something I think probably now the Global Fund is thinking in that line, which is good. We are hopeful that kind of deployment innovations will take a lot more traction in the coming years. Thank you.
Luchika Ditti wanted to weigh in again. Luchika?
No, I just want to say one thing. It's a very good question of why is not scaling up enough. I want to bring to your attention, is actually the money. It's beyond that. All the things that Ishibu said is the money. And Chris, Colin, you already referred to it in saying that, let me tell you all something. Only 48% of the people diagnosed with TB in 2023 had a molecular diagnosis. 52% of people were diagnosed using the microscope or clinically. This is completely crazy and unacceptable, because it means that people were receiving a diagnosis in which they didn't know if it's a resistant TB or not, and they received a diagnosis similar to what Robert Koch was doing it. Robert Koch, if he came here in a laboratory in any country looking at the microscope, will feel comfortable, but all the rest, it's very different. And we have all the tools, and we have the people, and it's a crime that there is no chance to scale up because of the lack of the money. This is the problem. We can have discussions a lot about the new tools. If we don't make them available, we will continue diagnosing TB with the rats and the microscope and clinically. And this is just purely a lack of money, because in TB, money comes from domestic and global fund. Global fund gives 18 cents for every dollar invested for TB, and the domestic are, especially Africa, are giving below 10% of the needed budgets from the domestic. That's where we are. So just to clarify that.
Thank you, Luchika. I'd like to bring in another dimension. We have colleagues from the Global Fund with us, including Patrick Royal, who's with the team that works on labs and in general work on resilient and sustainable systems of health. And wanted to look at general innovations, not necessarily commodity specific, since Lindsay alluded to supply chains and labs are crucial in general. Patrick, want to share some thoughts?
Thank you very much, Mark, and for the team for having me here. As you'd mentioned, the Global Fund has invested an enormous amount in integrated laboratory systems, strengthening to the amount of 550 million since 2021. And that's through our Grant Cycle 6, the COVID-19 response mechanism, and the current ongoing Grant Cycle 7. Our overall lab systems investments are very much explicitly cross-cutting, supporting countries as they integrate HIV, TB, and other priority disease service delivery towards achieving impact against the 3 epidemics. These investments are all made within the context of a very rapidly shifting landscape of what disease response looks like, with exogenous threats like emerging pathogens and climate-exacerbated disease testing, the readiness and the resilience of lab systems in the countries that we support. So with diagnosis being a very clear prerequisite to treatment for most climate-exacerbated diseases, lab systems are very pivotal to adopting innovative solutions to rapidly respond to the changing demands, drive sustainability and cost effectiveness, and trial new approaches to maximize resources. Importantly, our support to lab systems and access to diagnostic commodities is very much critical to ensuring that countries meet universal healthcare coverage targets. A few innovations really do stand out in the Global Fund programs. First, integration of diagnostic services informed by data-driven design of the networks operating in countries. And second, the regional modalities of delivering technically complex interventions that are very much tailored to the region-specific needs and communities that we're serving. Considering integration and diagnostic networks on an individual country scale, delivery of diagnostic services is definitely not a one-size-fits-all approach. Individual countries have leveraged innovative solutions to bring diagnosis closer to where patients are, tailored to their context. For instance, in Zambia, integrated priority of HIV testing with TB testing on the GeneXpert platform both generated cost savings and made a substantial improvement to diagnostic access for patients. A patient seeking HIV diagnosis could then be tested for TB simultaneously, which reduces the number of interactions that they need to make with the healthcare services, and it increases the chances that comorbidities are found. Acknowledging that diagnosis doesn't just happen within a laboratory setting, there's a wide range of other supportive services outside of the lab that enable patients to access care. For instance, in Uganda, the Ministry of Health holistically redesigned the routes that samples are transported through from patients to a laboratory and reestablished how the results are returned. This generated a much higher proportion of specimens being tested closer to where the patients seek the diagnosis. So success here is owed very much to an innovative geospatial analysis approach called Diagnostic Network Optimization, or DNO, which Uganda generated, in some instances, over a 50% reduction in turnaround time, enabling faster diagnosis and, in turn, of course, faster treatment for patients. Adapting that approach to countries where diagnostic services are heavily concentrated in urban centers, like in South Sudan, it's critical to reaching underserved communities, ensuring equitable access to services. These system design approaches and innovations bring patient services closer to key populations, ensuring that we remove at least some of the structural and logistical barriers to seeking diagnosis and knowing one's status. Other countries are taking up DNO, like Laos, Papua New Guinea, Mozambique, Ghana, and more. This is really making a massive change to the way services are delivered. So shifting our perspective away from country-specific investments to broader regional engagements, our regional partners have taken the lead in developing, implementing, and iterating very compelling innovations that work best within their regional context, being mindful of the disease burden, the existing structures in countries within the region, and the epidemiological realities. For instance, in Asia Pacific, localized innovation is embedded within our engagement through the Regional Public Health Laboratory Network, delivering training, knowledge sharing, and support to 14 countries as they strengthen lab systems. With the countries themselves knowing which way to innovate and the best innovations to bring diagnosis closer to patients, the network is supporting a peer-to-peer learning platform in which a best practice that's been championed by one member or a country can be adopted by another with dedicated technical support. That same model has been very successful on the African continent, where, for instance, stakeholders from Uganda visited Ghana to learn about healthcare waste management, paving the way for the establishment of a robust program of their own in Uganda. In West Africa, our engagement with a consortium of partners like the Institut Pasteur in Dakar has seen sentinel syndromic surveillance aggregate clinical, epidemiological, and laboratory-based data. And this paints a very detailed picture of emerging pathogen threats. As it's expanded across 6 more countries, we've seen this innovative solution developed by Senegal already proving its value elsewhere by flagging viral outbreaks like dengue and chikungunya in Gambia and Mauritania, including the emergence of Mpox in some countries. Implications for communities, again, are enormous. This ensures that cases in far-flung communities are detected and that those communities receive the responses that they need. Finally, in East and Central and Southern Africa, with the leadership of the EXA health community, we've seen an enormous level of success generated by supporting TB reference laboratories as they seek accreditation as supranational reference laboratories. Since 2015, EXA has also been supporting labs to become accredited according to ISO 15189, which is the international standard for medical laboratories. And these initiatives embed regional capacity to support TB lab networks as they deliver services to patients. Getting ISO accreditation to laboratories and that capacitation to the laboratories enables verification of regionally manufactured diagnostics. And this is really the future of bringing the supply of diagnostics closer to patients and communities, enabling more rapid response where needed. A key outcome here is the advancement of self-reliance within the region, bringing expertise from within to support peer countries and enhancing the delivery of TB diagnostic services. To summarize, innovation, the true innovation in its nature is most successful where it's developed, implemented, championed, and shared by the countries themselves. Even more so when the experts, clinicians, laboratories, patients, and communities are at the heart of those innovations and innovative solutions and where they're shared. Back to you, Mark.
Thank you very much. And so we've had some provocative, thought-provoking observations from Lindsay Hayden about HIV, meeting youth where they are for self-testing, even via drone delivery, edgy work related to AI, driven screening for TB, and then more general labs and diagnostics. Before we shift segments, would anybody like to ask a question or offer a comment? There's a couple of interesting things that have popped up into the chat box. One on TB among minors from Vamajele of the Key Populations and Communities constituency. And then some questions about communities that Craig McClure raises in the chat box. We don't have to live within boxes, so you can reclaim your time on another topic if you want to pop in at a later moment. Dennis Owini from Uganda.
Thank you, Patrick. I guess on your point of bringing diagnostic services closer to the communities, I was actually thinking about test kits, simpler test kits where the youth can use, instead of going to health clinics or laboratories to test, is there a possibility of supplying more cost-effective test kits? I think what we learned during the COVID pandemic is that we can easily test from home without going to clinics to find out whether you're sick or not. Is there a possibility of providing those cost-effective test kits to the youth, especially the youth, to know whether their partners have HIV?
And any of our panelists wish to speak to that, including Lindsay. But Patrick, did you want to?
Sure. Thanks very much for the question. And I think that's quite a salient point. A major challenge here is where test kits are actually available and where the market actually generates and innovates in producing new test kits. Of course, with COVID, we saw a great deal of innovation take hold very, very rapidly. And one of the challenges in countries was adoption of those of self-tests, of RDTs. We've seen major advances in the ways countries validate self-testing, and so that does lay the groundwork for future innovations to take hold. Ensuring that the market is responsive to the diagnostic needs of countries, so that the producers of new diagnostic innovation. The Global Fund Next Gen Market Shaping Strategic Initiative and our associated strategy promotes the capacity building for regional manufacturing and procurement. It also drives sustainable procurement and supply chains, and most importantly, shapes innovation and new product introduction at scale. And so this is where there's an opportunity for Global Fund to very closely contribute to this. But again, the focus does need to be on innovation that involves communities and innovation that is responsive to their needs. And of course, if self-testing is at the heart of that, it can be advanced. We've seen this with HIV. HIV self-testing has been very successful, and there are larger laboratory systems initiatives that support the deployment of HIV self-testing. We have community health workers trained. We support proficiency testing schemes under EQA to ensure HIV tests are used correctly and that they are used to a high quality standard. And so all of these initiatives in consortium can make an enormous change, but we really do rely on the active engagement of the private sector, and a strong interest from private sector to continue innovating in the space.
Thank you very much, Patrick. For those in the room, we're going to pass on a break. Respect those who are online by keeping at it. If you need to slip out, the restrooms are by the elevators. If you need to pick up permanently, don't worry about being on camera. If you need to pop out briefly, just do. We're going to turn to prevention and some really exciting cases and discussion, I hope, on that. And I want to begin with HIV prevention. I know that now Mitchell Warren is vibrating with interest and joy as the fearless leader of AVAC. If I may, I'd like to start with Trista Bingham, who's kindly joined us. She's HIV prevention lead, program quality at the State Department's not so new Bureau on Global Health Security and Diplomacy, the amalgam between health security functions and PEPFAR. Just has a long and really remarkable career at CDC. But Trista, do you have some things to share, particularly about long-acting PrEP?
Sure. Thanks so much for the invitation. And yeah, just open up my remarks just by saying thanks for inviting me to this. And I think it was Becky Bunnell who referred me to you, but really exciting to be part of this discussion. I'm going to talk about our plans in terms of implementing long-acting PrEP in the coming years, and just wanting to go back a little bit to the history. And as a part of the package of combination HIV prevention options, PEPFAR introduced oral daily PrEP in a handful of countries in 2016, and then scaled from 15 to 49 countries between 2018 and 2023. PEPFAR programs have initiated over 6.8 million people on oral PrEP, which represents about 90% of all global initiations to date. Currently, we have 12 million people initiating on oral PrEP annually. And while oral daily PrEP is a very good option for many in our PEPFAR supported programs, we are aware that people will benefit from additional options that suit their needs for convenience and discretion. Long-acting injectable PrEP, such as CAB-LA and lenacapavir, provide more choice in HIV prevention and higher effectiveness through a greater potential for adherence to the medications. PEPFAR has worked diligently over the past couple of years to make sure that broader PrEP choice is available to help reduce HIV infections in the countries we support. Beginning in February 2024, PEPFAR launched our first long-acting injectable PrEP programming with CAB-LA in Zambia. Currently, 5 countries are offering CAB-LA in their PEPFAR-supported PrEP programs, and another 7 are expected to launch by the end of this year, 2024. Adding to the expanded PrEP options available to PEPFAR programs, we are also excited about the news on lenacapavir, given the Purpose 1 and 2 trials and the early efficacy results shared since this summer. We are working internally at PEPFAR headquarters and closely with our Global Fund colleagues to chart the path to scale for both CAB-LA and LEN injectables as soon as possible. We fully recognize that communities and individuals will benefit from having multiple options for prevention products, and we will be working over the next 6 to 8 months to ensure that PEPFAR programs are ready to deliver multiple injectable PrEP options and look forward to more options on the horizon. To fully advance PrEP choice, we are laying the foundation with Global Fund, our partner governments, civil society, and other community stakeholders with the following plans: supporting and training the PrEP workforce, including ongoing in-service training that enables full choice counseling and reduces provider stigma, building a supply chain able to take on new products while ensuring regular availability of key prevention commodities, use of continuous quality improvement for context-specific improvements to enhance service delivery packages to make them scalable for delivering PrEP choice, consideration of the local context, including extension of decision-making authority to the county or facility level, and the involvement of local communities and civil society organizations in the design and monitoring of new PrEP options, translation of implementation science findings into the health system and community service delivery system to increase PrEP coverage and scale. We are currently convening monthly calls to discuss and share challenges and successes of PEPFAR countries that have launched CAB-LA this calendar year. We have 2 excellent examples of country programs in Zambia and Ukraine that have introduced CAB-LA. So Zambia was the first to introduce CAB-LA in February 2024. They have expanded rollout from 4 sites to 30 sites, offering CAB-LA in all 10 provinces. They will continue to scale as they receive more products centrally from PEPFAR. We recently learned about a very innovative initiative in Zambia, where they are working with a soap opera network on 3 different storylines around PrEP, including CAB-LA. The storylines include polygamous marriage with 0 different couples, adolescent girls and young women, and men. They shared this on our last monthly update meeting. In Ukraine, despite extremely challenging circumstances, the PEPFAR team successfully implemented CAB-LA in August of 2024. Healthcare workers and social workers engage with current CAB-LA clients to discuss concerns before and after injection, and then provide reminders for a return for the second injection at 1 month. They have 98% return at that second injection among just 100 people that they've had drug to initiate with. So there's currently a waiting list to start implementation and recruitment of clients. There is a desire to scale their CAB-LA rollout to additional sites, and the country team has requested additional product to support 1,000 clients across all regions where they're working, and this will start in March of 2025. So as PEPFAR continues to prioritize injectable PrEP introduction and scale up, we aim to specifically enhance uptake and effective use of PrEP for key populations, adolescent girls and young women, pregnant and breastfeeding women, and those in serodifferent relationships. As we build on our lessons learned from CAB-LA, we are looking forward to strategically introduce lenacapavir. We hope to position LEN as a catalyst to accelerate HIV programming to reach 2030 goals. And this means a particular focus on person-centered prevention programming with multiple PrEP product options. And LEN will serve as an opportunity to reinvigorate HIV programming to support large scale up of testing to link those who test positive to care and initiate those who are eligible onto PrEP, all while emphasizing decentralized PrEP delivery. And that's it for my comments, and just turn it back to you, Mark. Thanks.
Thank you very much, Trista. Also sharing perspectives, I'd like to call on Saira George Carballo, who's in Spain. She's Senior Program Manager for Product Introduction and Access for AVAG, a very close partner of Friends. Saira.
Thank you so much, Mark. Hi, everyone. Good evening, good afternoon, good morning. My name is Saira George Carballo, as Mark said. Really delighted to be here today, and great to be following Trista, with whom I work very closely on a key initiative that I'll talk a bit about today, one that we work on at AVAC, many different partners, the Coalition to Accelerate Access to Long-Acting PrEP, which, as you may have guessed by the name, is primarily looking at how we can optimize access to the new long-acting options in prevention, which is really code for how we can do better than we have done before. And so to talk about that, I think it's really important to try and look a little bit at the foundation from which we come in long-acting PrEP, not to reiterate Trista's comments, but just maybe to look at it from a different lens. In 2023, 3.5 million people were taking daily PrEP to prevent against HIV infection. And as compared to 2017, this number is a huge success. I think the number in 2017 was around 200,000 people taking daily PrEP. And so that's a huge increase. And in many ways, that is a success story. But I think many in the HIV space would agree that the opportunity for innovation that came with oral PrEP that was first approved in 2012 was squandered and has been squandered in many ways. I think there was probably a lack of sort of collaborative and cohesive vision, maybe a lack of ambition on how far we could take oral PrEP, and maybe an expectation that was unfounded that the existence of the product meant success of the product, whereas we know that just existing doesn't prevent infections. We need to kind of have holistic, well-planned programs that can really approach how we reduce infections well. So how do we use innovation to prevent us from repeating the same mistakes as we have made with oral PrEP? It's complicated. I don't need to tell anyone in this room or online that that's the case. Moving people from a daily pill to products that have different modalities and frequencies, whether that's the monthly dapivirine ring or the new injectable options, which are cabotegravir and lenacapavir, is no small feat. And adding to this, that we need to maintain choice for the user by maintaining access to lots of PrEP options simultaneously. That algorithm is really complex, and everything needs to be managed very carefully. And so to sort of make sense of that, let me walk through some of the lessons that we've learned from oral PrEP and that we are trying as part of the coalition and at AVAC to integrate so that we do better. There are lots across demand generation, delivery data, so I'll just highlight a few and then keep it at that. Firstly, I think we've learned one really big area is investing in expanding demand generation itself. So ensuring that we socialize PrEP for the general population whilst using sort of specific tailored outreach for specific user segments. Secondly, looking at how we replicate successful approaches from service delivery models that help users to actually access and then stay on PrEP. That includes integrating PrEP into sexual and reproductive health services, and also having community-led, non-discriminatory services in place. Lastly, increasing resource allocation to HIV prevention to facilitate national scale-up and to really see things do better in country. So with cabotegravir, tepivirin vaginal ring, lenacapavir, and other options that are coming in the pipeline, there's a real opportunity to reimagine how we can translate, the existence of the product to delivery and ultimately really impact infection numbers. Already the coordination behind the products, these new products, has been innovative in many ways, with originator and generic manufacturers really moving quickly to get generics to market, procurers moving quickly to purchase quickly, but also listen carefully to what countries want and need. Civil society advocating very clearly and passionately for lower pricing and access to a low price for all countries, and donors providing innovative funding to accelerate access. And that's just, a few examples, many other stakeholders doing many other things. And lastly, I think I'll just end on the fact that the coalition itself is an innovation, because the coordination of those activities really needs to be front and center to do well on access to the injectables and the ring. We have three main objectives and sort of approaches in how we do that. One is building on those lessons learned from oral PrEP, as I said, and coordinating the activities between procurers, donors, ministries of health, civil society, manufacturers, and many other stakeholders who are key. Secondly, we look to jointly identify strategies amongst all of those stakeholders to try and overcome access challenges and not sort of have discussions in vacuums, but try and do that across stakeholder groups. And then thirdly, using advocacy and consistent messaging to really ensure that options are available as quickly as possible to all who need them more quickly than ever before, which is no small feat, but we're seeing improvements as compared to oral PrEP already. There's a lot more I could say. I will stop there. And just to reiterate really that AVAC and the coalition's mutual aim is to move from, unfulfilled opportunity in some ways to really seizing innovation by doing things differently for the injectables and for the ring. Thank you so much. Happy to take any questions.
Sarah, I'll see if folks want to address some questions or comments your way, but I wanted to call on Emily Gibbons, our key partner at Gilead, who I'm sure has some things to say with regard to long-acting injectable PrEP.
Sure. Thanks, Mark, and thanks to you and Chris for convening this today. I think it's a really important discussion. And I appreciate the fact that actually the Trista and AVAC and the coalition kind of led off in their comments, because I think Gilead has been very clear from the start that we do need to do this differently, and that the importance of community consultation in guiding our access plan has been fundamental. And that really started at our clinical trial design level. So we work very closely with community on designing the Purpose 1 and Purpose 2 programs, and we're told quite clearly that we needed to make sure we had as broad a population base as possible so that we could get the right indications, and also that we should include pregnant women because that's a reality. So I think from the very start, we understood that we had to do our trials differently, and really the incredible results as a result of the scientists and the community that participated are really putting us in this strong position that we're in today. So several years ago, we started planning in earnest for access for lenacapavir for PrEP, because obviously the burden and where we can reach most public health impact are in many of the countries that PEPFAR and Global Fund supports. And we have been in very regular and strong dialogue with many of the partners that you can imagine. And I want to thank AVAC, the coalition, Syra and Mitchell for the really constructive role that they played in the coalition and facilitating a lot of these conversations and making and elevating some of the key points through the donors and also community partners. And so early on, long before we are in the situation where we actually had the good data, it was impressed upon us that we had to be mindful of a few things, because you can go really wide, but that the things that were most important that we heard from community, from PEPFAR, from Global Fund, from Gates, from all partners was speed, price, volume, and implementation, that these needed to be front and center. So we have been very mindful of a speed to market program, and I'll explain what I mean by that. So first of all, we wanted to make sure that if if this product is approved, that we would have dedicated Gilead supply to make sure that there was not a delay in when people from other more what is considered higher income countries get it at a different rate at when people who actually could potentially benefit more from it. So we've been very clear at working with our partners to understand demand. And anytime there's new product introduction, that is very, very complex. We are obviously fortunate to be following ViiV. It's really hard to be first to market. And I give them a lot of credit for kind of the work that they've had to do to try to adapt to a changing environment. But it certainly made us very intentional about trying to understand what the product demand would be. We will, of course, work with any country that wants to directly procure, but the reality is PEPFAR and Global Fund are going to play a very central role, which is appropriate with their leadership. Second, on price, certainly understand in the constrained budget environments for PEPFAR and Global Fund coming up on a big replenishment that, that this is the reality, that there's only so much budget and there are responsibilities within HIV for treatment, sustaining people on treatment, and also through the sustainability of the HIV program, investing in prevention. So, we work. So that's why we've been so intentional about voluntary licensing. So this is something that we've done that I think is innovative, is that several months before FDA filing, we have signed agreements with 6 voluntary licensing companies, because we know that different companies may have different ways of being innovative that could drive price down. And so it was very important. We've initiated tech transfer. We have been laser focused on getting those agreements signed in different territories, and really support the fact that the sooner that we got that tech transfer doing, the sooner that there would be opportunities for them to potentially offer solutions that that might be needed in the global ecosystem. I think, again, going back to speed, we worked very closely and just community and collaboration. Our regulatory filing priority list is public. We announced it in June. That was not a Gilead list. That was a list that we consulted on with PEPFAR, with Global Fund, with many experts, and said, if we are looking at the 1 to 2 to maybe 3 years that we will be primarily the supplier, what do we collectively think is most important? And I can say, I can share freely that the list changed based on that input. And so that's been very important. And then finally, outside of volume, there's implementation. So I really appreciated Trista's presentation. PEPFAR and Global Fund have been very generous with kind of what they think needs to get done. But I think that's the most important, because we have this incredible product, thanks to the scientists and the community, the clinical trial participants. But it does need, even if you tick off all the other things, speed, price, volume, if the drug isn't actually making it to the people who will benefit, then you actually you failed. So I think we feel very committed, particularly in the years in which we're in the driver's seat, to make sure that we are kind of wrapping around or not driving, but wrapping around the needs of the donor communities and the communities that are actually getting product to people, and supporting those efforts. And I think just finally following up on a point that Trista and others have made is, I think choice is most important. So obviously we were the innovator for oral daily PrEP, incredible product. We don't think it should go anywhere, but the truth is people aren't being adherent to it. And so, with lenacapavir, you could be protected on day 2 for 6 months. So making sure that people are fully cognizant of all the different options and ultimately picking the option that works best for them, because, what we've learned so far is with the limited options to date, we're not moving the needle in the way that we need to. And so expanding that pool and bringing on new things, including innovations from other companies like Merck, which has an oral monthly several years to the horizon. Like, these are all really good things for our community. So again, just appreciate Chris and Mark supporting this, and then also all the work of community and the donors that have really informed Gilead's plans over the last 2 years. We're very hopeful for the future.
Emily, thank you. And that's great. And also you're making this general point that we have to have layered approaches, and their previous approaches, we need to make them better. We add things to the toolbox. As we pivot now to malaria, I think of the great excitement about the malaria vaccine, but the modeling for its effectiveness depends on sticking with other elements, whether it be the latest generation bed nets that Amar Ali talked about, or spraying or other things. We have a particularly valued partner in Friends Private Sector Advisory Council, SC Johnson and Son. They're working with some other partners of the Global Fund on things that have to do with behavioral change as you introduce innovations. Tom is head of the Healthier World Group in the office of the chairman and CEO at SC Johnson. And I wondered if you might share some things that you have been doing in your perspective.
Yeah, definitely. Thank you, Mark. And just a shout out to Srishti and her team. I can't imagine what it takes to pull all of us together at the same time. And I mentioned to her too, I appreciate how especially communicative you are throughout the whole process. Nothing was left to chance. So thank you for that. So yeah, I'm with SC Johnson. We're a privately held family-owned company that's been around for about 140 years. We've kind of got that humble Midwest thing going on where we don't talk about ourselves too much. So you might not have heard about us. But we're in the insect-borne disease space. We probably make a lot of products that you've used, like Raid or Bagon or Off or Auton. We've got sales in just about every country and operations in about 70. We get confused with Johnson & Johnson a lot too. We support them very, very much. So ironically, they were founded the same year as we were too. So that just adds to some of the confusion there. I've got the good fortune to be part of a group called the Healthier World Initiative. And as Mark mentioned, we're focused on prevention. We prevent insect-borne disease for the world's most vulnerable people. We were officially formed about 10 years ago, and since then we've reached maybe 100 million people or so with different solutions, ranging from products to education to construction and health clinics all across the gamut. And one of the key themes is we do this with no profit for SC Johnson. I won't belabor the business model. We still try to establish business models where others throughout the value chain profit, but there's no margins for us as a company. Speaking towards the engagement of communities and the work we do, from a personal perspective, when I was approached to join this group, I was pretty excited, but deep down I was thinking, really, what do people in low and middle income countries need from a bunch of knuckleheads in Wisconsin like me? Like, is that really the right way to do it? And our chairman and CEO Fisk was almost evangelical that whoever is part of this group will be spending time immersed in the lives of the people we're trying to serve. And as much as I love somewhere like Rwanda, it doesn't just mean going to the Radisson Blu in Rwanda for a cool conference and hanging out for a while. It's really immersing yourself. And so that means, sleeping on the floors of mud huts in Uganda, tapping rubber trees with mobile workers in Myanmar, or working on cocoa farms with farmers in Ghana, so we can really understand how they live their life and what's important to them and what their priorities are. I may have taken it too far. I've gotten malaria a couple times, and I can't decide if I should be proud or ashamed of that. It's probably somewhere in the middle, but that's the kind of immersion we do. Taking it to a few tangible outputs of that, what does that lead us to? One of them is a product like this. This is a spatial repellent. This is called Guardian. You just hang it in a space like this, keeps mosquitoes away for over a year. And it doesn't just push it to your neighbor's house too. It essentially confuses them and knocks them down. I often get a little embarrassed or sheepish sometimes holding this up, especially when we're talking about vaccines or genetically modified mosquitoes. Like, that's amazing stuff. And I can say it was intentionally designed like this, really with three key benefits in mind, driven by not just the end users, but people that engage with this. It was designed first so that the end user didn't have to do anything about this, didn't have to engage with it, didn't interfere with their lives at all. There's a family I stayed with in Ghana many years ago, and the mother of the household, while I was there, got malaria. And I was thinking to myself, oh, this is great. I'm going to figure out how she got it. I'm going to come up with some cool solutions. She's going to be so proud of us. And despite my hubris at the time, she kind of, I'm paraphrasing, but she essentially put me in my place and was like, I don't want malaria, but it's just a way of life for us at this point. I got to feed my family. I got to come up with money to send them to school. I got enough things to think about. Malaria is just one of the issues I'm dealing with. And we hear things like that on a regular basis, either almost a fatalistic attitude about malaria, or, you know what, I worked too much in the sun today and I got malaria, or I ate the wrong food and I got malaria, maybe misperceptions about it. And that really drives us and serves as a foundation of solutions we put into place. So something like this was intentionally designed. So just hang it up. You don't even think about it. You don't interact with it at all. It just works. It's designed with community health workers in mind too. We all know they're the true heroes of anything we're doing. And so obviously something that's lightweight, easy to distribute from a distribution perspective, flat, easy to get out there. And then from a manufacturing perspective, too, I know Amar from Vestergaard mentioned the work they're doing in Nigeria to set up local manufacturing, and we do the same. We manufacture this in Nairobi, Kenya, and we're working on setting up manufacturing in Buenos Aires, Argentina, too. It would have been cheaper to do it in somewhere like Southeast Asia or China, but our intent was to manufacture where the diseases are. And there's plenty of nice narratives around that too, with, the job creation, of course, but also there's people that are manufacturing this now that have grown up with these diseases, and they're the ones making a solution to address it. So it's kind of this cool full circle narrative around it. We also spend a lot of time with community health workers, again, at the foundation of everything we do. And I think we know they work 24/7, a lot of them voluntarily, and they're so trusted. And we work closely with ministries of health and national malaria control programs to try and develop what community health workers tell us they need, whether it's expertise, whether it's tools to help them do their job better. As far as the partnership with the Global Fund goes, we don't have a WHO policy recommendation yet. We're working on that. I know we all know how fun the process is to get to that point. A lot of clinical trials, of course, so we're on that journey. But we focus in two key areas with the Global Fund right now, both of them in Nigeria too. One is around capability building. And I think, I'll speak for myself, I'm really self-conscious about not wanting to be the obnoxious American company that comes to town and says, here's how you do it, good luck. So again, we engage with the ministries of health and the national malaria control programs and the Global Fund teams on the ground. And we have, I'm going to get the exact wording wrong, but it's one of the world's largest privately held urban entomology centers, which is just a lot of words to say we've got some pretty smart medical entomologists that work for us. And so we embed them in with country teams to listen to them, to work with them, to help on capability building with the skills that they're requesting, the skills that they want, the skills that they need. The other thing we work on is social behavior change, and I won't pretend to be an expert at it, despite us trying to do it all the time, but it's tough, right? Like it's tough for a couple of reasons, and I think most of us realize how commoditized the space is, and so we've hit on it a few times already. There's a lot of times they're just not funding for something like social behavior change in a commoditized market. I think the second challenge is that they're human beings, right? Like I think about myself sometimes. I can't convince my wife to stop making chocolate chip cookies because I'll just devour them all. And not only can I not convince her, I can't convince myself to stop eating them. And I know I shouldn't do it. And it's just basic things like that. And I empathize with the folks in the HIV and AIDS and reproductive health space. Like you talk about, decision making, a lot of times that, in the heat of the moment, you're maybe not making it up here, you're making it somewhere else. And we run into that a lot in the insect-borne disease space. So we kind of run the full gamut from trying to create solutions that require as little or no behavior change as possible, just what's going to fit into their lives as simply as possible and require no behavior change, to the other end of the spectrum and probably leverage a lot of the same programs you all might, where it's ranging from radio to community events to enabling community health workers, and they're the foundation of everything that we do. So I'll pause there, hand it back over to you, Mark. I'm happy to answer any questions.
That's great. Oliver, you had a general question that you posed to me about ensuring trust in innovation. Would any of our contributors, especially in this segment, want to say a word about trust building? To getting people to use commodity, or have trust in one intervention versus another?
I can speak at it at a couple levels. I mentioned to Jeff at the beginning too. We run into that a lot, especially when somebody like me says, "Oh, we're not trying to profit off of this." Yeah, right. You're a multinational company. What are you really doing here? So ranging from, we've met with government officials ranging from presidents to ministers to, whoever, and they're always skeptical. Like, what do you really want? Are you looking for tax breaks, or what's the deal? And a lot of times it's just been consistent, relentless messaging around, like, we want to try and prevent a disease, and we want to work with you to do it. We want you to you can throw the fancy words around like co-creation or collaboration or whatever, and yeah, there's some of that, but it really is, it takes a few swings to really get there, I think. And I'd be reticent or potentially even distrustful if I was in their shoes too. And then even from an end user perspective, again, something like this is super innocuous, and I think it's like, oh, that's no big deal. But okay, you're telling me to hang this in my home. What's really in this thing? And I can't even see it's working. Like, what is it really doing? And is it harming my family? And I think it's a salient point in a lot of what we've been talking about, but it really is engagement with the people that do have trust in the communities, like the community health workers or like the National Malaria Control Programs. It isn't us in this room or on the call necessarily going in and trying to convince people. It's working with them to determine what they need and allow them to lead the way.
Thank you. And we've done pretty well in an overly ambitious agenda, but I want to leave time for the sort of cross-cutting discussion that we end with lessons for spurring innovation, the Global Fund's role in engaging communities. As a kind of bridge from what we have talked about into that integrative discussion, I'd like to call on Alexandra Scott, who's Managing Director for Project Last Mile. And again, reinforces the notion that it's not just commodity-specific innovation, but innovation such as supply chains. Alex.
Thank you so much. Thank you for having me. Good evening I'm dialing in from Munich. Good morning. Good afternoon to everyone in different locations. I'm pleased to also follow on that last point around trust building, because I'll explain a little bit about who I am and what we do, but we've spent a lot of years building trust, both in terms of our engagements with ministries of health, as well as better understanding consumers and patients to help build trust with the services that are being delivered. So I'm Alex Scott. I'm very pleased to represent another longstanding example of partnership between the Coca-Cola system, Coca-Cola Foundation and the company, as well as the bottling partners in Africa and the Global Fund that brings innovation to health systems. It's referred to as Project Last Mile. And so given the affiliation with the Coca-Cola system, obviously building trust and supporting and working with ministries of health is an important topic. We've been running since 2009. And I think from a lesson learned perspective, one of the key ways that we have built trust, is by demonstrating the value of starting small and then scaling to bigger, but also leveraging the partnership with organizations like the Global Fund who have the relationships with ministries of health, with local partners to say, we believe that there is value in this. We are willing to take a risk on it when it's new. Are you? And that was transformational in getting us to be able to engage and support ministries and bringing the innovations from the Coke system to serve them It took about 2 years before we got a country to buy in, from 2014 to 2016. So, you know, that's kind of one lesson learned and kind of point towards the value of the engagement with the Global Fund. So for just a bit more context, Project Last Mile was set up in 2009. It was in response to a question: if you can find Coca-Cola products in very rural and remote locations in Africa, why not medicines? And so Global Fund, along with the Gates Foundation, the Coca-Cola Company, catalyzed this pilot. And since then has brought on USAID, PEPFAR, Gates. USAID and PEPFAR, Gates was a core member already. And the focus is how can we bring the core capabilities of the Coca-Cola system in Africa, which is operating in all 54 countries on the continent, bring their global and local networks, their IP from across the value chain to support ministries of health, to strengthen health systems. And so it started with a supply chain focus and a route to market focus, getting products to the last mile, hence the name. It's since evolved to look at across the capabilities of the Coca-Cola system, to include marketing, strategic marketing, understanding consumers for behavior change, cold chain optimization, and supporting enterprises and enterprise development. So with that in mind, I'm keen to emphasize that in addition to the innovation around treatment and diagnostics, equipment, health systems also need innovation in the way they do business, in the way they operate, their systems, their processes, their approaches to things. And I do think, given everyone, you know, around this table, that there's a lot of value that the private sector is and can contribute to that, as we've heard so many examples of. So I think the behavior change one is a really interesting one that I'm going to kind of dig into a little bit, but particularly relevant to our work are innovations that we're seeing needed and value for around optimizing product distribution and delivery down to the last mile. You know, as we talked about, these innovations are only as valuable as they are utilized, and as they are accessed. So that's a big piece. And then, of course, you know, getting more and more into leveraging behavioral science innovations, understanding kind of innovations in behavioral science, consumer strategy, to look at how we can change behavior to encourage the uptake of these products and innovations that are being delivered. I'm bringing the Coca-Cola lens because that's where I'm sitting, but, you know, Coca-Cola and companies like Coca-Cola, many here, are intentional about designing with the consumer's needs and wants at the center of what they do. So not only do you find Coke in rural and remote locations, of course, but you also find people in those locations who know Coca-Cola and they love the brand. That is not by accident. There's a lot of innovation and science and effort that goes behind that. A lot of judgment calls, as well, as my marketing team and subject matter experts would say. And so, you know, I think the key point being that we also need to be looking at, and the Global Fund is a key enabler to this, accelerating innovation in the process and ways of working to make the innovation products that we're talking about relevant. So I can share a few examples from our work to maybe ground it a little bit. As an example, kind of a market research tool, a neuroscience-based market research tool, ZMET, Zaltman Metaphor Elicitation Technique, for those of you who may or may not be familiar with it, is utilized, among others, in the Coke system to dig deep into understanding the why and trying to better understand the ambitions and motivations of why people make the decisions they make, that leans on kind of metaphoric expressions. So we use that, among others, to design a men's health brand in South Africa, applying the strategic marketing approaches and these innovations that ultimately reached millions of men and contributed to notable increases in HIV testing among men in South Africa. Another kind of innovation opportunity that we see as being very transformational coming from the private sector that we're working with ministries of health in a couple of countries on is reframing how behavior change communications are managed in the public sector. So typically, as we all know, SPC is very fragmented. Individual organizations, like Tom mentioned, have relatively small budgets focused on behavior change and SPC, short timeframes to spend that money down. So it kind of lends itself to a fragmented landscape of people having different messages targeting the same consumers to achieve the same outcome, but not aligning with each other. you see consistency in the way Coca-Cola's brand is executed. It's localized, but it's consistent across every market it operates. How do we bring the innovations and the processes that that system uses to take kind of a brand building approach for national level campaigns, looking at people as people, not as their diseases, and then bringing all the implementing partners who do the work along with the Ministry of Health underneath that to drive change with one unified message. On the supply chain side, just a quick example. I know I'm not tracking my time like I should be. Mark, you let me know if I'm going too long.
Wrap up soon. He says.
Okay. Well, I can share other examples of it, but ultimately, I think the message from my side is that it's critical to work with partners like the Global Fund and the other donors who have the trust and relationships with these ministries of health to help think about the innovations we need to implement in the systems to make these products and tools and diagnostics work and reach the people who need to reach them. And, since 2009, we've been working with the Global Fund and other partners, and we've now been in 17 countries in Africa and are continuing to do the work. So I'm very appreciative to be here. I'm continually impressed by all the incredible work that's being done and love to see private sector leaning in. So thank you.
Thank you, Alex. And I appreciate it. We've got some other stars I want to make sure we get into this integrative discussion. I'd like to go now to Dr. Huma Abbasi, who is General Manager for Global Health and Medical and the Chief Medical Officer of the Chevron Corporation. Chevron co-chairs the Friends Private Sector Advisory Council with ViiV Healthcare. And we really appreciate your support for such convenings and the report that will be flowing from this. Dr. Abbasi.
Hey, thank you. Good morning and good afternoon. I'm hoping that you can see me and hear me okay. Yes? Okay, thank you. I see some nods here. So, well, thank you for having me here. Apologies, I couldn't be there in person, but virtually, I have been enjoying hearing the conversations, and thank you for having me listen in. Just great examples of how impressive technology we have now and examples of innovation, treatment, diagnostics, and especially when communities are involved. I was following through some of the comments in the chat that were being made in the earlier sessions, and somebody said why malaria cannot be eradicated. And that really, made me think about my career in the past. I've been now I'm going to age myself, but 20 years in managing infectious disease and leading corporate programs on HIV, malaria, and tuberculosis. And this just takes me back to the time when I was in healthcare and working in a developing country where I saw the devastation and the damage that diseases would bring. And it's and I am excited about the future. I don't want to go take us through a negative loop here. We just hearing this conversation and seeing the results of our partnerships that we have, it just makes me feel very, very excited and glad to be part of this conversation. So we know, and it really, I want to hone in on the aspect of bringing communities, and we know that working with communities is a critical piece for successful and sustainable progress in global health. These are the communities that are mostly impacted by healthcare changes, by policies, by processes, and community members are the ones who ultimately need preventive and life-saving practices, products, and tools. And I just go back to my experience in the beginning, like I mentioned, I know a time where community voices were not part of this discussion and how some really solid, good programs did not produce outcome. And then I also think about some of the programs, like if I take an example in Nigeria, when we were struggling with some of our programs, and we brought in peer health educator program and brought in community members to help us give the message and educate people and spread the word, and how successful the program became. So that was a testimonial to how important it is to involve the communities. We know in remote, vulnerable, and underserved populations, it's the community health worker. And sometimes, being a doctor, I can say it here, like sometimes it's not the doctor, physician, or the nurses, but it's those trusted members in the communities who are the main actors in identifying health risks, deploying resources, and advocating. It's one thing for a doctor to sit and present in PowerPoints, but it's another when a person who has that experience, that example, who understands the culture, goes and talks about these programs. And we've seen examples that relate to education, testing, and surveillance. Community health workers also, I think, have a unique understanding of the experience, the local culture, the socioeconomic realities, and where they serve. So it is really important to hone in on this aspect of our program deployment and make sure that we are not only including communities as a stakeholder, but actually developing programs that are community-centered. So that is a little different from just saying that, well, let's take your feedback. That means that we are proactively engaging with the community members in design. And I also have to note so many challenges to addressing gaps are certainly with discovery and development, but how efficiently and effectively methodologies, products, and tools can be translated, integrated, scaled up, and sustained in a real world setting. And fortunately, we are making progress. So why am I here? And, I just want to go back and take a moment to talk a little bit about Chevron, like our colleague shared earlier about their company, where we have over 145 years history where we have worked, lived, done business, built capacity, and partnered with governments, NGOs, private sectors, organizations, community leaders in every continent. And I certainly, have not been involved in all these years, but in my career, I have seen the advantages of working with the local governments and partnerships. It's interesting, last month I was sitting addressing a group talking about a public-private sector partnership. And the topic was, this was a group of parliamentarians who are working on health policies, and the subject was trust. And I found myself talking about global fund for 15 minutes out of my 35 minutes that I was given. And that is, again, a testament to how we appreciate the partnership with yourself, Chris and Mark, and Global Fund. We have a history of working, and I can see the advantages that this organization has brought to the underserved populations and in countries where we really need products and tools. Our health goals remain focused on prevention, protection, and providing culturally relevant evidence-based programs. Co-creation by end users and subject matter experts is a critical success factor. And with an iterative process, whether it be digital, data, supply chain, or technology, we focus on these. It reminds me of the reference, don't build it for me without me. And this is the point I was making earlier about having communities at the center of this program. I do want to talk a little bit about Global Fund. It would be remiss if I didn't, when I come to these meetings, and I know I'm very aware of the time, but let me just talk a little bit about this organization. It is an organization that has been continually adapting and adding significant value for connecting innovators and deploying solutions in the communities. I think working with organizations and NGOs like Global Fund, it really helps us to bring those solutions to the communities. And it's been a really humbling history of working with Global Fund and friends of the Global Fund. So just to quickly highlight a few of the Global Fund key roles. One is with its multi-stakeholder model, incorporating the private sector and affected communities at the board level and in country coordinating mechanism, incentivizing innovation and market shaping with its pool procurement, ensuring a predictable, sizable market for innovators, achieving scale to make deployment of innovation more affordable at lower unit prices. And I know we talked about this in our earlier session. And then, last but not the least, and very critical, is prioritizing communities' access to health products and role in caregiving, because if we don't have these community members, then what use is our programs? In closing, I just want to thank you, Chris, Mark, again, for having me here, for having me listen in to this great conversation. I will close by saying that we need us all of us here around the table, all of us who are participating in this discussion, all sectors, stakeholders, societies, regions, countries, communities, to be part of the dialogue. Technology will continue to rapidly change the consumer landscape, and I believe that health sector must keep up with the pace and be inclusive. D&I, EI, diversity inclusion is very important. It's important to have those stakeholders, and it's important to have the communities participate in the discussion. And I know, Mark, I saw your comments in the chat about a report. I'm going to highlight a couple here. Great resource examples from Friends of the Global Fight, including the reports that won Private Sector as Partner in Civil Society's Essential Role in Global Health. Another one, Digitizing Healthcare Demand and Supply in Africa, a People-Centered Approach, and the private sector as a key partner in health system strengthening. So thank you again, and I'm here and will continue listening to the dialogue.
Thank you very much, Dr. Abbasi. And I note Patrick Chamwolo's point in the chat box about these innovations reaching communities. And maybe that's something that we can linger on as we have the last part of our conversation. I'd like to turn to Austin Bafuna, who is Executive Director of Afro Global Alliance, a Ghanaian working in Nigeria. He's also serves as Vice Chair of the Board for Stop TB Partnership, which means he works for Luchika, right? Even though the governance arrow should be the other way around. Austin.
Thank you, Mark. I think you got it the other way around. Nigerian working in Ghana.
Oh, sorry, I spoke.
Yes, thank you. Well, first of all, let me say thank you to the Global Fight. I think inviting me to this meeting makes me happy, because at least you can create more space for the TB response, and also to the Georgetown Law Center colleagues. Thank you so much. I must say, good discussion, excellent participation as well. But I think we need to do more in terms of, need more action now, and let's talk, because we've been doing a lot of the talking. So obviously, I want to start by saying that, yes, we have a lot of innovations in TB space, especially in diagnostics, treatment, and also care. We have vaccines actually in the pipeline as well. We have 6 new TB candidate vaccines in phase 3 clinical trial. Very likely that at least one vaccine may be available to roll out during the last part of the GC8, which is very good. Even also when it comes to new TB infection test kit for latent TB as well, which are mainly skin tests, but more accurate than the tuberculin. So these are certain things that are already happening in TB. Again, we see in TB over the last year a lot of ambition and energy towards finding and diagnosing all people with TB. On community side, I want to say that we see a lot of multiplication of networks, both at the regional level, national, and also at the global level as well. And these are very strong networks, which their capacity are built, thanks to the Stop TB Partnership, for supporting most of these organizations to build their capacity to the level. And you can see that a lot is happening in the TB space presently. I see, a lot of great, demand coming from TB survivors as well, and CSOs, including the one on an equitable allocation of global fund resources, with the TB 33 campaign. I'm sure most of you have seen a lot of this happening on social media. It's TB 33 campaign, and if you even have your phone, you can actually, access the QR code, which you can see from here. But I will share the link online for people who wants to sign the petition. I mean, everybody agrees that TB needs more money, you know. So unfortunately, our friend Patrick from the Global Fund dropped off, but I hope the report is made available for for read, because often at time the Global Fund, which we always see as the bigger elephant in the room, supposed to be around to listen to some of these discussions happening. And we are mentioning good things about the Global Fund, but at least we also have to have them in the room. On it, I think innovations are great, because we talk about innovations a lot, but only if people can be diagnosed, treated with this, because without having access to these tools and a significant coverage, this remains as desired tools, you know. But for me, they are never accessible. So it's like as if we don't have the tools. And I just mentioned the TB33 campaign, and TB is severely underfunded, even though some of the TB high burden countries are scaling up their own domestic finances, as we observe with India, Indonesia, Philippines as well. But the gaps are huge globally. We already know that in 2025, there are at least 10 TB high burden countries that will run out of finances to procure diagnostics and also treatment. So these are very alarming problems, and we need to give listening ear to some of these issues. In the face of dramatic funding shortages, investments in human rights, gender, communities, and also even stigma, we go to zero. We can blame the TB program that they have to prioritize. But again, what are we doing? This is why we propose that we invest smart, and also the funds are going towards tools that can be used for diagnosis of TB and other diseases, and smartly fund communities and civil society, because I hear everybody is talking about funding civil society, funding communities as well, because these people can actually capacitate to intervene for TB, but also any other disease like we saw in COVID, even during crisis as well. We're all talking about pandemic preparedness. We need to build capacity of the civil society to also be ready to match the capacities of the public sector and the rest. So I know that Mark wanted me to be very short, although I wanted to use half an hour for my intervention, but I want to be brief. So thank you, Mark, and I appreciate any question, any comment. Thank you.
I appreciate it, Austin. Mark Dybul, professor in the Department of Medicine at Georgetown University's Medical Center, and the former chief of both the Global Fund and PEPFAR, PEPFAR's architects, has a little time before he has to go. Do you have a thought or two, Mark, you want to share before we all have to go?
Yeah. Thanks, Mark. Maybe just briefly. And it's good to be another knucklehead Midwesterner from Wisconsin. And you didn't say cheesehead, you said knucklehead, so I know you're really from Wisconsin. We don't use cheeseheads, other people do. Maybe just to take a slightly different tack on the need for community by focusing on recent events, not just in the US, but Germany, Japan, France. We're heading for a fiscal cliff for external support, or we can do something to, in a sense, go back to where we were 20 years ago and be the creative, innovative part of development to show the way. And it's kind of up to us to do that. And I go back to the beginnings of PEPFAR and the Global Fund, and we focus on the technologies, which we have to. I mean, without bed nets, without antiretrovirals, without TB drugs, we wouldn't have much interventions. But in the end, it was the communities who always figured out how to get it to people, how to get services to people, how to do it most effectively, efficiently. And I believe we've kind of lost that connectivity to the communities. And if we don't pull it, we have the opportunity to pull it back. We at Georgetown University, and Deus is coming back from a retreat, so he wasn't able to join today, but have been working in a couple of countries to do precisely that. And not just to bring things to communities to say, here, do this, or to on sustainability work plan, say, here's the work plan, you guys write it, which we seem to be doing, but to actually begin by starting in the community for asking them what their problems are and how they would solve them. And what we found is they solve a lot of problems on their own, and only then raise it to the government when they need support. And if we want to have more efficiency, which includes delivering products where they are. I mean, let's just take PrEP right now. I've been in a few countries. They're basically giving PrEP to anyone who tests HIV negative. That's a waste of money. If PrEP is focused on people who are at the greatest risk, which communities can do in very novel ways. They have some great ideas on how to do that. We will have a bigger impact. They also have great ideas on how to get more efficiencies in delivery of services. And I'm talking not only about in villages, but communities that include the government and include the private sector. We always forget about the private sector's communities. And when we think about the private sector, we think about companies, which we should. And thanks to all the companies who engage and are here today, but they also include investors. And we tend to focus on the billionaires, the multi-billionaires in Africa. We all go to Dangote and Tony and with Patrice Motsepe and Strive, and that's great. They're very engaged. But there are people who, and I just talked to some who are at a retreat right now, hundreds of millions to billions, who want to invest in the health sector, who want to participate in the health sector, but we don't involve them. But they're part of the community. They're part of their communities that want to actually invest their money in their communities in health. And so I think if we focus on community for solving problems, including how do you best get products to people? How do you best deliver services? How do you more efficiently deliver services? And then how stimulate local, and when that happens, what we've seen is governors, mayors start increasing their contributions, financial contributions, and focusing on problems that matter to the community for HIV, but also things that relate to HIV. So in Kenya and Eswatini, we saw increase in funding for road safety because boda riders who are at high risk for HIV and TB also need road safety. We saw, and not a penny of it came from HIV, TB, and malaria money. We saw increases in clean water because that's what mattered to the community. We saw increases in investment in entrepreneurship training because that's what young people wanted to see, and young people are at high risk for all the diseases we're talking about. So if we engage communities fully, they will solve problems. That means us changing how we operate. We can't be centrally driven in the way we've been. But to be honest, I think if we don't shift and shift quickly, we're not going to have the money to do any of it. So now's the time to act. And so I think this is an incredibly timely event. And I'm sorry I'm going to have to jump off soon because I'm actually going to meet with one of those very wealthy people who might want to invest in health.
Go mobilize those resources, man. I'd like to turn now as we approach the end, and please note what I say in the chat box. We're going to run about 6 minutes long. If you need to go, please go. But I'd like to turn now to Alicia Fleischer, who's at USAID. She's chief of the Health Financing and Economics branch in the Office of HIV/AIDS there, and has experience not only in the agency, but at the World Bank, the Gates Foundation, and the Institute for Health Metrics Evaluation.
Mark, thanks so much. Tough act to follow, Mark Dybul, but I have to say that Mark heated up for me quite well by talking about fiscal cliffs and health financing, which is something that I think about on a day-to-day basis. PEPFAR is laser focused on sustainability right now, and that means that we are too in the Office of HIV/AIDS. And at USAID, we've been working with and will continue to work with the private sector for years to come. And so our work in that area has meant work on market shaping to influence global markets for ARVs and diagnostics, thinking about market-based approaches to expand access, and thinking about the regulatory environment to really sort of boost the availability and quality of medicines. When we at USAID think about sustainability of the HIV response, a key priority for us is integration of HIV with PHC, primary healthcare. We see PHC as really being fundamental and essential to achieving global goals, which of course include HIV, but also TB and malaria, the other diseases that we've talked about today. And we think, especially, my team and I think a lot about how the financing of HIV services, prevention, care, and treatment can help to make those services more accessible, more affordable, and how that financing can really be more equitable so that we see a reduction ultimately in out-of-pocket spending by people at the point of service. And so we think kind of a lot right now, especially about what is the future of health systems going to look like in the countries where we work, as countries are reorienting their health systems towards a primary healthcare orientation. What support do we need to provide to help make that happen? And so when we think about what a future state of the HIV response might look like, PEPFAR has said that the future state of the HIV response is one in which the large majority of the HIV response is led and delivered by government or delivered by other domestic entities with a lot of support from communities and government accountability. At USAID and especially in the health financing and economics branch, we're thinking about how to support countries to really optimize resources. And so what does that mean in an environment where donor resources are declining kind of across the board, where countries have extreme macro fiscal constraints and are facing debt distress? Domestic resource mobilization efforts are going to be more complex probably than ever before. And so how do we make better use of the existing resources while also talking about, of course, still needing more money for health? So we're not leaving that off the table, but just thinking even more about how to make best use of resources that we have, again, to think about really kind of driving those improvements into in equity and quality of healthcare, ultimately to see improvements in health and to sustain the gains that we've achieved. Mark, thanks so much.
Thank you. A rich discussion. Let me turn to Chris Collins, President and CEO of Friends, for some themes he spotted that he thought were particularly salient.
Thank you so much, everyone who's here and who spoke on this. It's been a great discussion, and I'll summarize it in 30 seconds.
2 whole minutes.
2 minutes. So just some top line things that I heard in various different ways. Absolutely, it is about innovation and then making those products accessible. And as Emily said, we need to be thinking about that from the beginning. As Luchika said, none of this amazing progress is going to mean anything unless people use it. And Dr. Adekunle from Novartis talked about the need for an armamentarian. It's access to the new product, but it's also access to all the products that are choices around it. So how can we, in delivering new products, bring in other things and make them available and advance the choice agenda? Lindsay at Elton John talked about some specific things to reach youth, like decentralized care and horizontalizing care, pop-up events where young people are. So innovative ways of reaching target audiences. Patrick at Global Fund talked about several things the Global Fund is doing: integration of diagnostic and other services, regional modalities, advancing regional manufacturing and self-reliance in the region. And that's key to access too, is that actors in the region have the resources and the expertise to do what they need to do on access. The Global Fund's Next Generation Market Shaping program is another way to bring price down and increase access. Lisa from USAID also really talked about the role that integration of HIV is going to have in terms of access. Very complex area, but definitely integration needs to be on our list of thinking about it. We kind of did an access spotlight on long-acting HIV prevention and heard from Trista at the Global Health Security Bureau about a lot of things they're doing to enhance access. They're doing things like the workforce and supply chain and quality improvement and understanding the local context, but also really relying on community service delivery and how important that'll be. Sarah of AVAC talked about another innovation, which is the Coalition to Access Long-Acting PrEP, and bringing multiple players together in a whole new way to facilitate that discussion, and the need for tailored outreach. Emily, again, said, think about access from the very start. They've tried to do that at Gilead, learn lessons from rollout of the earlier long-acting. She emphasized speed, price, volume, and implementation. Those are things they heard when they talked to community actors about what the priorities are. Another major area is just absolutely the essential role of communities in all this. Dr. Charles talked about how they provide local knowledge, cultural context, and insights. Global Fund prioritizes community involvement. Crystal in Uganda talked about that community engagement helps build trust. And for access plans to happen, they need to be accepted by the community. And, community involvement is all about accepting products, shaping products, but also drives acceptance of them. Engagement is what builds acceptance, she said. Dr. Abbasi at Chevron talked about it's not just including communities, it's about making projects community-centered, and that co-creation with community and all major stakeholders is a critical success factor. She said, don't build it for me without me, quoting others. And she identified key global fund roles in all of this, including engagement of multiple stakeholders in governance, incentivizing innovation, market shaping, going to scale with products, and prioritizing community access. Mark Dybul talked about, said that communities have always figured out how to get services to people, and they can help identify and solve their own problems. And it's a matter of involving them and listening to them. Communities can focus on people at greatest risk, and they can also really get at efficiencies. So to do that, though, to really hear community and involve them, we need to change the way we operate. This can't be centrally driven anymore. Communities at the center from the beginning. And Tom with SC Johnson talked about immersing yourself in the local context, capacity building, but it's about helping people access the skills they want. Another major theme that we heard was partnerships from Dr. Charles, Luchika, Alex from Project Last Mile talked about, partnerships are so critical. And actually, one of the advantages of the Global Fund is you can use it to help leverage their relationships with ministries of health as well as with communities. Finally, it's about innovation, but it's also about money. There's no question that lack of funds being committed to the responses is really inhibiting our progress. Colin talked about that we're seeing a great level of country ambition now in TB, but there just isn't the money to get basic TB services to folks. Luchika underscored that 52% of people with TB were diagnosed using a microscope, which is crazy in this day and age. So we need to be thinking about funding that can scale new technology, but also, as I said before, put the basics to people as well. It's a crime, she said, that there's no chance to scale up what we need to because of the money. Great discussion. Thank you.
Thank you, Chris. It's a superpower of yours. Oliver.
I'll be extremely brief, I promise. I just want to start by thanking Friends as a partner on this, Mark, Chris, Shristi for putting this together. I thought it was such a rich discussion. Also my colleague Sophie for organizing this. And I think it was an exciting conversation. I won't attempt to summarize it because Chris, you've done that so well, but centering community in this, localizing manufacturing to build health economies while not being naive to financial challenges. I think we've heard so much today, but most of all the excitement of the new innovations that are coming downstream. We at Georgetown, all of Georgetown, from the law school and the business school to the medical centers and the labs, are committed to trying to contribute to this work in every way we can. A particular focus of the Institute is going to be this issue of trust. We can see declining trust in public health from misinformation, disinformation, other reasons. We will be leading a Lancet Georgetown Commission on faith trust in global health over the next 18 months to try and explore the faith community role and helping to restore trust. So for those that are interested in the trust question, please do engage in that work, and very much looking forward to the report that we'll be developing out of this, and hopefully future conversations and dialogues on this topic with you all as we go forward. So thank you very much.
Thank you. And thanks to Srishti Banerjee, who was the glue and behind this all coming together. Thank you.